I'm Dr. Fadl. I'm an interventional radiologist here in Pittsburgh. I'm actually the chief interventional radiologist for Integrated Vascular and Interventional Radiology Associates, as well as being the medical director for Pittsburgh North Surgical Center, which is our dedicated surgical center down on 19 in Cranberry. So not too far away. We're essentially neighbors. So happy to come by to discuss with you guys a novel therapy for osteoarthritis of the knee in patients who are, symptomatic knee pain. And that therapy is referred to as genicular artery embolization. So I have a little PowerPoint slide, essentially a PowerPoint slide. I'll try to go through it very quickly, just to kind of hit the main points. So when we talk about osteoarthritis, essentially what we're talking about is a very progressive, debilitating disease that it can affect multiple joints. And essentially, in terms of the demographics, osteoarthritis is very common. As we get older, we wear down the lining of the joints, and wearing down the lining causes inflammation and then subsequent narrowing of the joints, and in doing so, causing pain. So, it's a debilitating disease, very common, as I said, among, as we get older, with around a 13% prevalence in women and about 10% in men after the age of 60. So in terms of the pathophysiology, how does osteoarthritis, what's the mechanism? So essentially you have some type of inciting event to the joint, okay? And what that does is it causes secondary inflammation with recruitments of what we call cytokines. So these factors within the blood that essentially get recruited into the joint to try to aid in healing the joint. But in doing so, it causes a cascade of events to happen. One of those cascades is that it causes neoangiogenesis, which is a very fancy term for creating these new blood supplies or blood vessels in and around the joint. And in doing so, it brings in more blood. And by bringing in more blood, it brings in more cytokines. So you have this cycle of cytokines, increasing blood vessels, blood volume, and so on and so forth. But unfortunately, with the cytokines and increasing the blood volume and blood vessels to the joint, you also create inflammation. And that inflammation then translates into pain. And really what we find is that the inflammation, specifically into a portion of the joint called the synovium, which is a portion or lining of the joint, that's what causes the majority of pain in these arthritic entities. So how does osteoarthritis cause pain? Just as Maine mentioned, basically you get this recruitment of cytokines, you get the inflammation, and it causes then secondary changes into the joint, okay? And what we often see, on x-rays is that you'll have either narrowing of the joint, you may have something called subchondral cystic changes, once again, another fancy term for a little bit of bubbling underneath the covering of the joint within the bone. You may have osteophyte formation, which is just abnormal bony growth from the joint capsule itself. And all of this refers to or causes pain. So how does this manifest clinically? So oftentimes, patients will describe, things such as stiffness, pain, inability to, go down a flight of steps without having significant pain, specifically when we're talking about the knee joint. And basically just overall debilitation in terms of movement within the joint. Things that we look for as clinicians is, do you have a decreased range of motion? So can you flex and bend your knee appropriately? Do you feel bogginess or like a fullness in your knee? You may have something, a secondary consequence of the arthritis, which is developing fluid within the joint spaces itself. You may get these bony enlargements or these osteophytes. So these are all things that we're looking for on the clinical exam.
How about a torn meniscus? Is that like the trauma to the knee?
So torn meniscus usually is probably secondary, not so much from osteoarthritis. It can be caused because of maybe pain in the contralateral knee, and then you're favoring the other side, and in doing so, you're kind of putting your body out of whack, per se, and that can cause secondary damage to the other knee joint. In terms of the workup, so I'm a radiologist by training, so I like to look at pictures all day, essentially. So what we're looking for is, the typical things: the narrowing, the subchondral cystic changes, any signs of an effusion or fluid on the knee. These are all indicative of osteoarthritis. So, what are the management options that are available to us for knee pain? So essentially, it's a spectrum of things that we could do. So on one end of the spectrum, it's traditional kind of conservative care. So either taking over-the-counter medications to help with the pain, potentially maybe even getting injections, other modalities. Dr. Stupi can speak to that. So pharmacologic regimen. And then on the opposite end of the spectrum is the more, aggressive treatment management, and that's surgery, right? Going in, chopping at the knee, and replacing it with metal, which your orthopedic surgeon would love to do, right? So, these are just kind of typical pictures of what you would see, in orthopedic surgery. And this is what we see afterwards. So you could see that, the joint now has been changed and it's all metal. So what are the limitations? There's no perfect treatment, as I like to say. So on one end, when you're treating conservatively, right, maybe you can't take enough medication to really help with the pain, right? Maybe the medications that you're taking have side effects, such as, causing stomach ulcers or just generalized pain. Maybe it can, you have a reaction to the medicines. And of course, surgery has its own set of risks, right? A surgerized knee doesn't necessarily mean a happy knee. You can easily still have pain after the surgery that could be like lifelong. So where do other treatments fall? Well, somewhere in the middle. So between the conservative as well as the surgical approach. So that's kind of where genicular artery embolization comes into play. So what is it? So essentially, genicular artery embolization is a minimally invasive intervention by which an interventional radiologist, such as myself, gets into access into arteries that feed the knee joint. And by doing so, what we do is we typically take some pictures, initially by injecting IV dye, to kind of get a sense of what's going on in and around the joint. And what we're looking for is number one, abnormal arteries that are leading to areas where patients are describing where they have pain, where they have point tenderness, or we're looking for signs of inflammation. And signs of inflammation are things like hyperemia or increased vascularity to the area. And oftentimes it'll look like someone kind of smudged the picture in and around that region. So what's the mechanism by which genicular artery embolization that it works behind? Well, so what we do is we get access into these arteries and we take some pictures, and then from there, what we want to do is we want to break the cycle of inflammation. And the way we do that is by decreasing or getting rid of that neovascularity, those abnormal blood vessels that have grown. So what we do is we utilize special tools, one of those tools being a microcatheter, which is a thin tube, thin like spaghetti, allows us to get access into these very distal branches of these arteries, and we inject microparticles, which are very, very, very minute, tiny particles, which are usually made out of different materials. And what we're looking to do is we inject these particles to kind of plug up the very ends of the arteries. I like to make the analogy, it's trimming a tree and or doing like bonsai. If any of you guys have done that, what you're trying to do, you're not trying to cut the branches of the bonsai tree. What you're trying to do is just prune around the edges to kind of, reshape the tree. And that's essentially what we're looking for. Is we're trying to get those jagged edges out in terms of the inflammation and therefore decreasing pain overall. So this is just kind of a pictorial look at what your knee arteries look like. So on the very left is an X-ray that you typically get, when we're working up these patients. In the middle is a pictorial, drawing, and then on the right is an angiogram, which is basically the technique by which we get images during the procedure when we're looking at the genicular arteries or the knee arteries themselves. So in terms of, patient selection, who's a good candidate, who's not, we look at, a couple of things. We look at, have you tried conservative methods? Have you gotten knee injections and are just failing knee injections? Have you tried oral medications? Are you tolerating ibuprofen? Is that helping? Have you tried other approaches besides just surgeries? So there are other things such as nerve ablation, where they go behind the knee and they target the nerves that feed the knee joint themselves, and they kind of knock the signals out. That works in a subset of patients, but not all patients. So what we're looking to do is we're just trying to find a subset of those patients who, number one, aren't good surgical candidates. Number two, who don't want to be surgical candidates. And number three, who have failed traditional conservative methods. And what's nice about GAE, or genicular artery embolization, is that it's an adjunct therapy. So you can do that as well as doing injections, as well as continuing your medications, as well as doing other treatments that may help with your pain. So, ideal versus poor candidate, right? So the ideal candidate is someone who has mild to moderate knee osteoarthritis. And we essentially score them on this grading scale called a Kellgren-Lawrence scale. So anyone who's a 2 or 3, the scale goes from a 0 to a 4, is really an ideal candidate. That's not to say that if you have a 1 or a 4, those outliers, that you can't possibly be a good candidate or get some benefit from the procedure. We're looking at patients who've had persistent pain despite the conservative method. Patients who want to avoid surgery, right? Not everybody wants to go under the knife and get a total knee, right? And so that just doesn't make sense for everybody. Patients who perhaps don't mind the aspect of surgery, but would not be a surgical candidate because they can't get anesthesia, or perhaps they're overweight and they need to undergo a physical therapy regimen prior to going under the knife. So, who's not a good candidate? I like to think everybody is a good candidate, but I'm a little biased. But some patients who are not good candidates are those that have very, very significant osteoarthritis of the knee. So patients who are grade 4, where it's almost bone on bone, there's no joint left. Patients who have, other diagnoses that may prevent us from doing an angiogram. So if you have very bad kidneys and you can't get IV dye, perhaps this is not the treatment, that you should undergo. Uncontrolled diabetics, patients who have peripheral arterial disease, and patients who perhaps have other reasons behind their knee pain that are more psychosomatic rather than actual knee pain itself. Patients who should really not get this procedure are patients who have very poor arteries. They have plaques in their arteries, things that can break off and travel down to smaller arteries, and patients who are allergic to contrast.
I have a question. Can you do this procedure to other joints, or is it just for the knees?
That's a great question. So a lot of my colleagues in and around the country have expanded the use of this method to treat things like frozen shoulders, and they're even expanding it to things like tennis elbow and ankle.
How about the hands?
Hands, a little bit more difficult because, the arteries down there are very tiny, and you don't want to really take out any arteries that are leading into your hand because you could potentially damage the nerves in and around the hand. So hands, I would say, need a little bit more time and a little bit more research to really find out whether it's beneficial. But I would say, the bigger joints right now, your hips, your knees, your shoulders, and then to a lesser degree, your elbows and your ankles. Yes?
Is the frozen shoulder surgery relatively successful, or is it still in the experimental stages right now?
You mean the embolization for? Yeah, so it's pretty successful. The data is not as robust as the knee data right now, but what we're seeing is that patients end up getting less pain, which then allow them to have better range of motion.
Okay.
So you're welcome.
And is this covered by insurance?
Yes. Okay. So if you were interested, what would you expect in terms of the procedure? So it's all done as an outpatient procedure. The procedure itself takes about an hour, maybe 2 hours to do at most. It's all done minimally invasively, so either through a small puncture in an artery in your wrist, in your groin, or in your foot. You're looking afterwards for pretty much around 1 to 2 hours of recovery, and once you get home, you're pretty much fully recovered. So, after the procedure, what we often like to tell patients is, what to expect. And so, I've had patients get off the table and have, go from 8 out of 10 pain to a 2 out of 10 pain with their knees, right? That's not always typical. What I like to say is that oftentimes patients can fall into one of two groups. You can either have a huge reduction in your pain or a minimal reduction in your pain. But ultimately what we like to see is that, there is some type of reduction. Now, about 1 to 2 weeks out, you'll start seeing really the benefit of the procedure. So you'll start getting kind of a peak of pain and then plateauing very nicely down to a new level of pain. So 1 to 2 weeks, you'll find that, you have better pain, better range of motion. Really what we often see is that at the 3-month mark, most patients will plateau in terms of their overall pain.
How does this procedure versus some people try stem cells? I don't know whether stem cells work, and I know they're not covered.
Right. So stem cells look to kind of try to replace the damage utilizing progenitor cells to kind of fill in the gaps of like where the damage has occurred. This is really specifically targeting the etiology of the pain, which is the inflammation. And so what we've found in our recent, studies is that looking at all comers, for this procedure, as long as your knee has not been surgerized, meaning that you don't have a knee replacement, we see around a 70% reduction in pain for about 2 years from the procedure, 2 years out.
Oh.
Okay? Yeah.
How about for the shoulders?
Shoulders still to be determined. So data is sparse there. So I would say, about 50 to 60% reduction. This is all anecdotal, 50 to 60% for about a year. Yeah. And so, and what's nice is that, you can have this procedure, and then if you decide, hey, I still want to get a knee replacement, then you can still get a knee replacement. This procedure does not prevent you from getting any other treatments that you may need.
Can you have that done again, let's say, if it isn't that?
Absolutely. Yeah, but we don't have like the long-term data. So, so what we like to do is we like to kind of follow patients out to 5 years and see if like they have really reduction in 5 years. But a lot of the data is right now kind of at the 2-year mark. But that's not to say that those patients won't have, pain-free symptoms out 3 years or 5 years or 10 years, or they may never need, a knee replacement, I will say that this procedure is not a time machine. It will not, if you have bad knees, it won't bring your knees back to that of a 20-year-old, right? But what it will do is it allow you to not have pain so that you can kind of do the things that you typically want to do. If you want to get onto an exercise regimen, if you want to strengthen your knee with physical therapy, if you want to have better, like just flexibility, mobility, this procedure is a nice adjunct, procedure for that. So here's just a case that I did a couple of months ago. So we have 58-year-old woman, long-standing knee pain, both knees, described 7 out of 10 pain, point tenderness all over the knee. She was on meloxicam, which is a non-steroidal that's often prescribed for osteoarthritic knee pain, and she was failing that, unfortunately. And she had undergone a number of other modalities, the Rooster shot or the Cool Gel shot, right? And something called genicular nerve ablation, where they go in and they freeze the nerve behind the knee. She failed both. And so she came to see me. These were the typical pictures. So these are kind of the typical pictures I get when doing a procedure. So we get into the artery behind the knee. Maybe I'll just point with my fingers so you can assume. So, and this is a shot of the popliteal artery. So this is the shot behind the artery behind the knee. And what you can see is on the second picture, there's this kind of haziness to the outside of the knee on both the outside and inside part of the knee. And that corresponded to her inflammation. This is what we see and designate as hyperemia. And so this is just another shot of me putting down my little catheter into one of the branches of the popliteal arteries. And you can see, again, there's that inflammation. So we injected a number of the arteries out in the knee, and this is what it looked like afterwards. So you can see all of that inflammation, hyperemia kind of went away. And so right after the procedure, patient had minimal discomfort. I think it was more because she had her knee kind of strained out for a prolonged period of time. But in a week or so, she was describing about 50% reduction in her pain. And ultimately, at the 6-month mark, she had about a 3 out of 10 pain. And she's been at a 3 out of 10 ever since. So, what are the clinical outcomes? So we've had, multiple trials done in and around the US and within Europe. And, all of them are really showing that this is a very safe procedure and it has high efficacy in terms of decreasing pain, which is the number one thing that we're looking for. As I may mention, 40 to 60% reduction in pain at 6 months with even greater reduction in pain out to 2 years. And also, there's gradual improvement in the overall pain profile. So it's not you go from 0 to, 10 to 0 overnight. There's an improvement over the course of that 3-month period, but most patients plateau and stay at that reduced pain level for about 24 months, if not longer. So in summary, the key takeaways is that this is a very safe procedure. It's minimally invasive. It's a nice adjunct to other modalities that are available out there right now in terms of if you want to avoid surgery. It has a very favorable safety profile. The safety profile is very minimal and the recovery profile is great. Okay. There still needs to be a little bit more research done. We don't have 5-year data, but that's hopefully soon to come. We'll look at other joints as well, as is kind of addressed. And we want to also look at this in conjunction with other therapies. So we do this in conjunction with giving a biologic, in conjunction with doing a nerve ablation. And how does that favor out? But ultimately, GAE, I feel strongly, will be a paradigm shift in terms of intervention for patients who have any type of musculoskeletal pain, whether it's a knee, whether it's a hip, shoulder. And I think that, given the profile and the number of patients out there with pain, this is just a great therapy to undergo.
Especially for somebody that's younger that can't have a knee replacement.
Exactly, yeah.
Because they have to have maybe a couple.
Well, an orthopedic surgeon at a certain age will tell you you cannot have a knee replacement because you're so young that you may outlive, the knee joint or the whatever joint will degrade, but you'll still then need a revision, right? Because you're so young. Yeah. So I have had plenty of patients who have come to me with that problem. So, all right. So this is just a little bit of contact information. If you guys are interested or know of anyone, there's that QR code will take you directly to my practice website, which is Ivera. There it'll.
Business cards?
I do. Yeah, absolutely. So if you know anyone with knee pain who kind of, I think all comers would benefit, I do free consultations over the phone, so I don't even necessarily need to see you in the clinic. I'm more than happy to talk to you over the phone. And then if interested, the imaging, everything, we take care of all of that. Yes?
Would you be interested in expanding this into the shoulder, or are you sticking to the knee for right now?
So right now, I just kind of sticking to knees and just kind of seeing, just building kind of my anecdotal experience, although I've done this for a number of years in the hospital. The primary indication when we used to do genicular artery embolization is the typical patient was patient who was surgerized, so had a new knee, but had bleeding into their knee, and it was causing a lot of pain. So the blood or hemarthrosis caused a lot of degeneration and pain. And so we'd go in and we'd block the arteries. And what we found is that blocking the arteries improved the bleeding, number one. That was kind of the goal. But number two, it decreased the pain. So we expanded out. I'm not adverse to, you know, having a discussion with a patient, but, you know, I like to hang my hat on, you know, kind of concrete data. And so I don't know, you know, typically a conversation would go like, listen, you know, there may be a good reduction in pain. You may not. It may give you better flexibility, mobility at the joint. It may not. You know, we kind of live in that, you know, 1 to 99% right now for total shoulder, for shoulders specifically.
Thank you.
You're welcome. Hips, yeah, we're expanding as well to hips. So the thing with the hips, as opposed to knees, is that there's a robust blood supply to the hip. And oftentimes it doesn't just come off of one source, it's coming off multiple sources. So you have to investigate not only the artery that's traveling down by the hip, but a lot of the internal iliacs, so the pelvic arteries, will give branches out to the hip. So. All right.
Your business card here?
I don't have them out. I will put out, I have some flyers if you're interested, and it has all the contact information. So, but thank you for your patience. I know it was somewhat of a long-winded presentation, so I appreciate your, thank you.
Thank you.
Thank you.
Yeah, thank you.